blood loss, transfusion reactions, blood groups, blood types. Do you know your blood type? This is the Real Nurses Talk Show. Let's get started!
Gonna make your day. Sunshine, gonna make your day.
I'm Mike Blood. I'm a former police officer with the city of Edina, and I try to get by in life, be as helpful as I can for others, and do no harm. Well, that was November 16, 2000. I went in to work the day shift, which is what I was working at that time. Then shortly before 10 o'clock that morning, our dispatcher came over the air and advised us that there was a bank robbery in progress at the bank at 69th and France. We knew that the caller was a bank officer calling on his cell phone. What I wanted to do was look for his getaway car. And the first vehicle that I noticed parked facing outward with no front plate on it was a green Ford Explorer. Our dispatcher said he's going out the back door now. And at that time, I was still a block from the bank, and I figured I had time to get out of the way and hide. About 2 seconds later, he rotated up an assault rifle and pulled the first round off from about 15 feet outside my squad. That round went through the passenger side window and struck me right by my hips. I grabbed the driver's door, threw it open, and ducked down, starting to run to the rear of my squad. As I circled, he circled to the front, spraying more rounds with his assault rifle. I realized that the only alternative was to play dead, and that's what I did. I lay face down, I took one deep breath, and held still. That day there were quite a few witnesses, and they saw the bank robber then come to the back of my squad about 10 feet away from me, and he put 2 more rounds in my back. Those rounds entered just under my right shoulder blade. After he put those rounds into my back, he walked back to his vehicle, got in, and I came back to clarity about the time he was getting into his Ford Explorer. The first day that I was taken in, we spent, from what I'm told, about 8 hours in surgery. And what they tried to do with the first surgeries was stop as much of the bleeding as possible. I have to say, hearing after the fact from the doctors, it was nothing less than a miracle that they were able to keep me alive, keep me going. But I really wanted to see my kids grow up. And the first thought actually was being able to walk my daughter down the aisle. And that happened last summer. I was able to walk my daughter down the aisle. What can you say to the people and the things that went into saving your life? Thank you, yes, but how do you say thank you for your life? That's what I try to do. I wouldn't be here without what ended up being, with 19 operations. I went through 120 units of blood, which is almost 15 gallons. If it weren't for a good blood supply, I wouldn't be here today. And I'm having too good a time at life right now, playing golf and fishing. I can't imagine an alternative. I'd like to say thank you to you for giving blood. My life was saved because someone gave blood. Who knows whose life will be saved tomorrow because you gave blood? It could be you. Thank you and bless you.
Today we have with us Dale Smith. Dale, it's so wonderful to have you here.
Thank you. Nice to be here.
Thank you for coming. He came to us in very, very short notice. So we're very happy to have him here. And you have been a nurse a very long time, haven't you?
Almost 34 years.
Oh my
Yeah.
goodness.
Yeah.
What made you decide to become a nurse?
Well, you know, I started out as a nurse's aide, very young, when they still let 16-year-olds be nurse's aides.
Oh,
and,
wow.
and I watched nurses work, and I thought it was interesting, something I felt I had aptitude, and so I just jumped right into it.
And you've been doing it since. Wow. And what do you like best about this wonderful work we do?
Well, early on, it was very stimulating because I like the sciences and I like to work with humans. As I get older,
As opposed to
as I've gotten older, it's a very stable
right.
position now, and it's become more easy for me and interesting as time goes on.
It is, isn't it? I mean, once you have the basics down,
Right.
yeah,
right.
you can truly enjoy what you do.
Exactly.
Yeah.
Exactly. Yeah.
And you know, you work locally, correct? You work in the Portland area?
I do. I
Okay.
do. My specialty is has been intensive care and rapid response for all my whole career.
So you know what? For those of us at home who do not know what rapid response is, could you explain a little bit to them what rapid response is?
I can. Just briefly, in 2006, Australia did a study that said if there was a group of people who could respond to patient needs in the hospital rapidly, that there was better outcomes for those patients. So now rapid response, what we do is if a nurse identifies an issue with a patient that they're uncomfortable with, they can call us and we could be there within 5 minutes instead of perhaps waiting for a physician who may be busy and it may take a half hour to get there.
Right.
So rapid response is exactly that. Within 5 minutes of the case, we can help to assess
So like
what's
if
going
their
on.
blood pressure drops suddenly or those
Or
type
they
of
have
changes.
bleeding that
Or they
is
have
unexplained.
bleeding like we're
Mhm.
going to be talking
Exactly.
today. And since he just reminded me, today's show is on blood transfusions. As someone who has administered blood very frequently over your 34 years as a nurse, what would be the primary reasons that people get blood transfusions?
The ones that I've worked with in the intensive care setting, many of them were gastrointestinal bleedings, ulcers, problems with the colon, and also chronic anemia. Folks who just come into the hospital feeling poorly, and we do some blood tests, and we find out that they're terribly anemic, and so we replace their blood at that time.
Right.
I haven't worked a lot with, say, trauma centers and things, open heart surgery and things like that.
I've done that. So
And
we
you
can-
have, right?
Yeah, so, and that's the other area where we do a lot of massive transfusions because of that severe instantaneous blood loss, and the system goes into major shock as
Major,
a result. Yeah,
absolutely.
but the type of loss that you're talking about, so this usually happens like over time, right? Like most often than not, it's not like a sudden bleed or something.
In the intensive care unit, what usually brings the patient in is the person in is a sudden blood loss. They
Okay.
see it, they go to the bathroom, and they suddenly see this terrible
Oops.
business. Exactly, and they have to move,
Yeah.
and they get dizzy, and they come in.
Yeah.
So those are the
are
ones
the
that
sudden
I've
losses.
seen most often.
Okay.
Yeah.
So if you had a person like that came in, went to the bathroom, and then they looked down, and instead of what they were expecting to see is like a pool of
Blood,
blood, and they get really dizzy and stuff, and they're brought to your ICU. What kind of tests would you do to diagnose the need for blood transfusion?
Oftentimes those are done in the emergency room before they get here, and
Okay.
the big things, the most important are the hemoglobin and the hematocrit, red cell.
So what are you
in the
checking
bloodstream.
for when you do that?
We are looking for hemoglobin is what carries oxygen through your bloodstream. Hematocrit is the percent of blood in the liquid part of your bloodstream. So
Right.
we look for numbers. The normal is for a man 12 to 16, hemoglobin, hematocrit 40 to 50 or so. So we're looking for those numbers. If we see you then start to, with symptoms, if they're down far enough, then we'll think about transfusion.
Okay. Is there like a standard for when, I know sometimes when your hemoglobin is like a 7 as opposed to the 14 where it's supposed to be for male, we sometimes transfuse and sometimes we don't, depending if the patient's symptomatic. And by symptomatic, we mean that they're dizzy, what other symptoms would we have?
Oftentimes you have the low blood pressure, the inability to move, the horrible sweating, the cold extremities, the very low kidney flow through, blood through the kidneys.
Because I guess when you don't have enough hemoglobins, you don't have enough oxygen in your body. So obviously your brain is not going to be computing properly. Your other organs are not going to get
Exactly.
So yeah, that would explain why your kidney will slow down too, right?
Exactly.
So for someone who's heard the word anemia quite often, what does this mean, and what are usually some of the symptoms we just mentioned would be related to anemia, to patients who are anemic, even
Right.
chronically, right?
The chronic anemic patients will come in, they're just come in because they're short of breath. The hemoglobin is so low in their bloodstream that they can't carry oxygen, so they become short of breath, or they have chest pains, or they're just tired.
And that's usually how people who are first diagnosed with anemia usually
Very much so.
find out that they are, right?
Very much so.
Yeah, it's definitely
Yeah,
tired,
they'll say
sickly,
I was looking a little pale, and then I started feeling this way, and somebody said I should come see the doctor.
Right.
We tell them these are the risks and benefits to a blood transfusion. Once they say yes, we can go ahead and take a blood sample called a type and cross match, and that makes sure that if you're type A, you get type A. If you're positive, you get positive.
Okay.
But we have to get your permission and your consent before we can do
Before
those
we
other
can do
things. Yep.
anything, just like everything else within the hospital, right?
Absolutely. Yep.
Yeah. So, what type of transfusions then would be available to this person? Do they have to come in ahead of time and give their own blood, or do we have blood waiting for them?
If you have a situation where you are actively bleeding, we have banked blood. Our American Red Cross in this area takes blood from donors, and we have it available to give. We don't give, we used to have this thing called whole blood where you'd see on, a lot of folks would see on all of the soap operas and things like this, this big bag of blood, and we just don't do that anymore. We just try to concentrate on giving the cells by
The
themselves.
ones that they need, like your red blood cells,
Red
or
blood cells.
plasma, those different components.
Exactly. There's so many different components of the blood that we use at different times.
Right.
Plasma we give for people who have clotting factor problems, and we give things like platelets for people who are, say, getting chemotherapy, which alters platelet function and things like that. So we can get a lot of different components with each blood sample, each blood bank.
So it's definitely not unusual for the patient on chemo to get platelet transfusions
Very
and stuff,
common.
right?
Very common.
Okay. You just mentioned the clotting factor, and I was just thinking about the other aspect. So you have the plasma that has a lot of clotting factors, and then the concentrated part of the plasma, like cryoprecipitate, that we can also use for that. And that's for patients that go into, that have some kind of hemorrhaging problem, right? Some kind of
Exactly.
bleeding.
Right, and the cryoprecipitate we give when we are giving other kind of blood products, other kind of volume, and we want to give specific products without giving you a bunch more fluid and volume that your heart can't handle.
Exactly, exactly. So I know a lot of people worry about this. When you get a blood transfusion, you're thinking, how safe is this? You've heard all the stories, blood in the past, people getting HIV or hepatitis and all this. It's quite scary. What are we doing to make sure that, people are not getting diseases from blood transfusions?
Well, the American Association of Blood Banks have a certain criteria, and also the CDC has a certain criteria. So they have a big 4 or 5 things they check very
Okay.
carefully with. HIV we've talked about in the
Right.
past, hepatitis B virus, hepatitis C virus, West Nile they test for. So they test very strategically of those high-risk diseases. Right now, for HIV transmission, it's 1 in 2 million may get HIV. Yeah,
And
so
that's in 2
extremely
million,
sick.
right?
Mm.
So that's extremely rare then.
Extremely.
Extremely
Yeah.
rare. So, but people do get, even though we do all this testing and stuff, people do still get some kind of reaction to blood sometimes.
They do.
And how does this usually manifest? Like, what do they?
Well, oftentimes it'll manifest itself with a bit of a fever. The body is rejecting the blood, not because it's the wrong type or the wrong ABO type or whatever, but because it has a protein in it that belongs to somebody else, and the body is very fickle that way. We don't
Right.
like things
They're foreign to
that are
us.
foreign to us.
Yeah.
And the way we react to that, one of the ways we react to that is fever.
Right.
and-
So you're
and-
having some kind of allergic reaction then?
Just like
Yeah.
you would if you had, if you were allergic to peanuts or anything else, you have the same types of reactions.
Right, right. And there's this other reaction that happens to the trolley.
Transfusion-related acute lung injuries we call trolley, and trolley is one of those things as through the last 30 years, we would have people who suddenly became short of breath within about 6 hours of the transfusion, and we'd say, well, we just gave too much blood for their heart to handle.
Right.
And it turned out to be something different than that. In fact, it was a
interesting.
reaction to the that the lungs had to this blood product, and basically it would hit them hard, and then we would do all these things, special things. Well, now we're finding that we need to just support them more and try not to get rid of a lot of fluid or do other things, but just give them the oxygen they need until that heals
That sounds like a good plan.
up. And it takes about 72 to 96 hours before the lungs get.
So, have you ever come across any studies that have to do with like efficacy of blood transfusions and things like that you might want to share?
Yeah, there's so many studies that are out there, and you have to really be very careful of how you pick and choose which ones you're looking at, particularly with our friend Google. But what I found is, instead of specific studies that I look at the CDC guidelines, and I look at people from CDC, American Association of Blood Banks, and things like that. I enjoy reading the studies, but I'm always careful about how I interpret them.
How you interpret them, and you have to worry about like sample size and
Very much so.
and almost always there's another study that comes and contradicts
Exactly.
something.
Exactly.
So, yeah. And so we are nurses, we give blood a lot. So what's the role that nurses have in assuring that the blood transfusion process is safe for the patient?
First of all, nursing nowadays, we used to just do what the doctor told us to do, and now it's brought out to much more responsibility. First thing we have to do is, are we seeing the same blood sample, blood result as the doctor? And when the doctor calls and says, I want 2 units of blood for Mrs. Jones, we have to say, wait a minute, Mrs. Jones' blood count is X. Are you sure you're talking about Mrs. Jones?
Exactly.
So that's number one. So the second thing we have to do is make sure that consent. Did the doctor talk with that patient, and have we gained consent?
Right.
Then once that's happened, we get the appropriate blood work. Once the blood bank has prepared the blood safely for us, we check it with the blood bank. Then when we bring it to the patient's bedside, we check it with another nurse, with the patient. Multiple steps, very much. And we, in the best case scenario, have the patient say their name and their birthday. Otherwise, we look at their band, and both of us have to agree that all these things, that the blood
Actually
test was
match.
right, that the consent was right, that everything matches before we ever hang it.
And checking all the numbers on the blood product itself to make sure
Absolutely.
that it is exactly what was typed and crossed for that patient and matches, right?
Very much so. And we
Yeah.
also have to know, our knowledge base is that if it's an emergency and the patient has to get O negative blood, which we can give to anybody,
Right.
that in fact that if they don't match, why aren't they matching, and what we can do about that, or
Right.
what should we do anything about it?
That just and reminded me of a very important PSA we need to throw out there. O negative blood, most commonly used blood in trauma, right? And there is always a need for that. So if you're O negative and you're out there, please donate blood because we need it. The American Red Cross
Red Cross?
and Puget Sound Blood Center as well in this area. They are available for you to donate, so please do. So what if, have you ever come across anybody who said on principle, for whatever reason, I don't want to get blood?
For religious reasons, for fear, as particularly when some of the HIV and hepatitis B were getting very more in the news in the mid-'80s. All of a sudden we had people out of nowhere saying, I won't take a blood transfusion. And in fact, I've had a couple in my career who...
The fear was warranted at the time too.
And it was.
Back then. It's so much safer now.
And I've had a couple of folks in my career who have actually died because that was their religious principle or their principle. And
so basically they were bleeding to death, but they chose not to take blood because their particular faith does not agree with blood transfusions.
Exactly.
Oh, wow.
Yeah.
Can you imagine that happening to a child?
I can't, and I don't work in pediatrics for that
So we
one
don't
reason.
know.
Pediatric is very complicated.
It's very hard, isn't it?
I put them on a pedestal. Yeah.
I do too. You know, little people. Yeah.
Exactly.
Okay, so for example, this patient has decided, I don't want this blood product. So what can we do then? So they needed some kind of surgery. How can we get their numbers up so that we can take them safely to surgery?
If it's a planned surgery that we know of, we can encourage the patient to take iron supplements and B12 and folate, things we know that make blood sample or make blood cells and make them competent. We can ask them to eat certain foods that also are high in iron. Green leafy vegetables are high in iron. If you eat meat, meat is high in iron, generally red meat. But
I'm sorry,
that's
we're laughing
debatable.
about this because his wife is vegan, if I may say that on the air.
Yeah, I'm very careful how I talk about meat, right, exactly. So, and always encourage them to be hydrated. There is some cases, and particularly some religious faiths that epogen, which is a drug, can be given that helps promote building. It's a naturally occurring hormone in our bodies, and we can offer it from a pharmaceutical standpoint to help build blood cells before surgery like this. There are also centers and this is it's not controversial, but it's very difficult because some insurances don't support these things, and it's a very complicated situation, but there are centers who strive to have what they call bloodless surgery, that they plan on it and they don't have to give, or they don't give banked blood.
That's pretty good. So are there any long-term effects that are associated with blood transfusions?
Not horribly. There's short-term effects in electrolytes. Blood transfusions interfere particularly with calcium in the blood. So in the short term, we will have to watch those with people getting large amounts of blood. In the long term, in some rare cases, there have been increased sensitivity, but a lot of that is environmental. Specifically, if I am in a position sometime in my life to be frostbitten, then I might react with what they call cold agglutins in a blood transfusion later on if blood is given too fast to me.
Got it.
Because it's cold. So there is some of that, but not wide.
So, I mean, there might be someone out there that's listening and they're thinking they don't know if blood transfusion is right for them, or they know someone who's in the process of trying to decide if they should get blood or not. What kind of advice would we give them? Is it safe to go ahead and get blood, or?
It is. You know, this is what I look at folks who come into the hospital seeking help, or to your doctor. You came to seek help. I've gone to my doctor because I'm feeling poorly.
Right.
So if I have high blood pressure, my doctor offers me medicine for that.
Right.
If I have this they offer me this.
Right.
If I go in feeling poorly and the my hemoglobin and hematocrit are low, and they offer me a blood transfusion, I have the right to say, do I want to go dragging through time still,
Right.
or do I take the blood transfusion knowing that it very well may immediately make me feel better?
Right.
And with the safety, just like if I take a blood pressure pill, may make me faint if it's not correct,
Right.
there are risks with blood transfusions. But
Got it.
I say to them, if you're feeling so poor you sought medical help, it's worth the risk.
It's worth it. It's worth feeling better.
Feeling better.
And obviously, it's not your baseline. That's why you're here, right?
Exactly.
Yeah,
Exactly.
I would agree with that. And wow, you've been a great guest.
Thank you.
This is painless.
Feel like it bled all over. And I'm O negative, so I can give to myself.
Oh, you can
It
give
was
to
very
yourself.
nice.
That's funny.
It was very nice. I've sought all kinds of venues to get rid of all this knowledge I have in my brain. So this is a nice venue to do that with.
We want to have you anytime.
Great, I'll be here.
You'll be here for our next show, actually.
I will be happy to be here.
Oh, awesome. So this is Dale Smith. He's educating you on blood transfusion. And I will see